I mean, we've done the basics. We did the basics in terms of your anatomy and biochemistry. And then you did the basic hematology last year. And so right now we're trying to give you more of a clinical slant. So it may feel like repetition, but what we do is we might review what you'd already done, but we build up on that with an eye on the fact that right now you guys are rotating and you are participating quite a bit in patient management. And so we do mention a bit about the labs, how to interpret them, and a bit about management, just to tie it all in so that it's not just the science part, but it's got a bit of clinical heme in it. So heading straight into hemolytic anemias, I know you know this, you've gone through the inherited ones, but just to remind you that hemolysis is defined as shortened red cell survival or a shortened red cell half-life. Sometimes you may talk about increased red cell destruction, but what we're really looking at is the age of the RBC being less that, it's usually 110 plus or minus 10 days. So once it's less than 100 days, that's what we'll term hemolysis. And I find often, like when I'm asking you guys in orals or we bump into each other and I ask you what hemolysis is, you tell me it's red cell destruction. So I always feel the need to point out that there is normal red cell senescence, which occurs when a red cell has aged. Yeah, at the end of its lifespan, it's broken down. But hemolysis is more than that. It's where we do have this premature destruction, we do have this shortened red cell survival or half-life. So it's not necessarily, the red cell doesn't really reach, its expected end of its lifespan, but it's destroyed prematurely. So forgive the repetition if you already know this, I'm setting a basis. It may be as a result of intrinsic defects, problems that are within the red cell itself, like the membranopathies you've discussed, or the hemoglobinopathies, or the enzymopathies. And I always like to point out again that if you remember, your red cell during hemopoiesis at some point extrudes all of its organelles. So to optimize or to be at full capacity for its true function, which is, that transport of hemoglobin to help with that oxygen carrying capacity. So it gets rid of, it's not dead weight. The organelles aren't really dead weight, but anything superfluous or extra, anything that's not hemoglobin is gotten rid of, which is why when there are problems with its structure or with its enzymes, there is such a problem and the red cell is destroyed prematurely because it doesn't have, that cellular machinery to repair or to make up for it. So if, it produces an enzyme that has a shortened half-life, I think you guys had talked about your G6PD-H deficiency, there's no room for it to produce more, because there are no organelles. So a lot of these intrinsic defects are covered in the inherited or, intrinsic hemolytic anemias. The second type, the extrinsic, are more of what we're covering today. The extrinsic defects are things from outside the red cell that may affect the red cell survival. So these are really quite varied. It could be immune mediated, it could be mechanical, it could be an oxidant or drug related, etc. Yeah. For both of these, they can both be inherited or acquired. You can get an inherited issue with, let's say, drugs or susceptibility to environmental problem, but more often than not, extrinsic defects are acquired. But they all lead to that shortened red cell survival. And this breakdown or this hemolysis can be intravascular or extravascular. So for the acquired, it's associated with the classical features of hemolysis. And there are two main categories that we're going to review. So they're the immune mediated, and in this case, the antibodies are really just, the main player in this case. And then and a lot of these are Coombs positive, and we'll go into that. For the non-immune mediated, they're quite diverse, and they're usually Coombs negative because, of course, it's not immune mediated. If you remember your transfusion lectures from last year, your Coombs reagent is an anti-immunoglobulin, right? So the immunoglobulin refers to the immune part, and hence the Coombs negativity in this bit. So sorry, I'm trying to turn off my phone. Okay. So let's jump right into the immune-mediated hemolytic anemias. So with immune-mediated hemolytic anemias, there's often immune dysregulation in that, okay, sorry, I should have mentioned that it could be two. So it can be either an autoimmune, and that's what we're going to focus on, in that there is an antibody produced, within, the individual's body against their own red cells. Yeah. And then there's alloimmune, which we usually cover in transfusion. So the allo antibodies are antibodies that are produced to non-self. And I don't quite recall if I put them in this PowerPoint, but when we talk about allo antibodies and allo immune-mediated hemolysis, we really talk about things like your transfusion reactions, where you're destroying red cells that have been transfused to you because of a non-self antigen, or things like hemolytic disease of the newborn, yeah, where mom has a different blood group from baby. And the two main examples we consider, and I think you'll cover this again in transfusion, are, for example, mom is RHD negative and has a baby that's RHD positive, and the first pregnancy is sensitization, and then with the second, now, if mom didn't receive anti-D, then mom forms antibodies against the baby's red cells, which have RHD, particularly if there's been an episode of fetal maternal hemorrhage. If mom was exposed to the fetal red cells, recognizes that I don't have, this D antigen, what is this, sees it as foreign, and then forms antibodies to destroy that. The other type of hemolytic disease of the newborn, which is more common but less severe, is the ABO incompatibility. And it's usually with a mom who's blood group O, who doesn't have A or B antigens on their red cells in terms of ABO, but has a baby that is blood group A or blood group B. And so this can occur with the first pregnancy. And if there's an episode of fetal maternal hemorrhage and mom gets, some of these blood group B cells in circulation from baby, recognizes that, I don't have this B antigen. So really just forms these antibodies and, actually already has in circulation. That's why it happens with the first pregnancy. And then may cross the placenta to try and destroy the baby's red cells. So those are usually topics we discuss for transfusion during a transfusion series, and we'll talk about transfusion reactions. I don't know if it's either me or Dr. Maturi giving them, but those are alloimmune. So for today's lecture, we'll focus on the autoimmune, and I'm just going to do a check to make sure I'm still online. You can still hear me. So maybe the class rep can just say yes or no, or everyone might have to talk.
Yes, Doc, we can hear you very well.
Thanks. Forgive me, I'm going to do a couple of those. It's been 2 years of this, but it's still very weird teaching a screen and not knowing if anyone's still there. All right, so back to the autoimmune. This really occurs when there is immune dysregulation. And if you remember from your immunology lectures with Dr. Barasa, Dr. Bontier, etc., we usually have any clones that are autoreactive, that seem to react against self, they're destroyed. But when there's immune dysregulation, some of these clones are not. And then we get these clones that do produce autoantibodies against, your own cells, yeah? And in this case, it's your own red cells. And generally, when we consider the autoimmune, we usually consider it based on the thermal amplitude of the antibody involved, and I'll go through that. So that's why you'll see the warm IHA versus the cold IHA, and I'll talk to you about that in a minute. I'm just going to point out the effector mechanism. So a lot of the time for the cell-mediated destruction, it's predominantly extravascular. And for the complement-mediated, it's predominantly intravascular. I need to get a shout out to Dr. Murigi, I borrowed a lot of slides from the lecture she'd given me. So I'm just going to mention that. I'm accused of plagiarism. All right, so immune again, we've talked about autoimmune against self, alloimmune against non-self, and some of the drug-induced immune hemolytic anemias are immune-mediated, yeah? So autoimmune. Again, antibodies produced by the patient's own immune system, classified according to the thermal properties of the antibodies or thermal amplitude. What temperature do these antibodies work best at? So we call it a warm IHA, yeah? If there are antibodies that are most efficient or bind most avidly to red cells at 37 degrees. Cold IHA work best below 32 degrees and may even work as low as 4 degrees. And often these may not be clinically significant because of that thermal amplitude. Like, what temperature do they work at? Is it a physiologic temperature? So for the warm IHAs, the antibody is usually IgG, but you can get more rarely IgM or IgA, but usually IgG, and they facilitate sequestration of the sensitized red cells in the spleen, okay? So you've got this antibody that then latches onto the red cell, it's attacking self, and then by the time they get to the spleen, that's where they're sequestered and destroyed. It can be primary or secondary to an autoimmune disorder, HIV, a lot of these lymphomas, we do get that because of that clone. They may produce a malignant clone that also has issues with self-regulation. So we can get an autoimmune hemolytic antibody, hemolytic anemia, sorry. This is the most common type. And as we've said, the antibody is most active in vitro at 37 degrees, okay? So it occurs in either sex, but there's a female preponderance, yeah? Especially in the primary AHAs, where you can find an underlying cause. It can occur in all ages, but you get a higher incidence in secondary in patients over 45. But if you look at the disease profile of causes of secondary warm IHAs, like the lymphomas, etc., those are patients who would generally be in that older age group. So you can, it makes sense, yeah? The clinical features are that of a hemolytic anemia. I'm so sorry, some things seem to be off screen, but I'll edit it before I send it to you. So, and the severity is varying and tends to remit and relapse. So you get these flare-ups and they go away. And so you have the symptoms of anemia, that breathlessness, that easy fatigability, and the signs also of that, in terms of the pallor, and then signs of now hemolysis, like your jaundice, and we've talked about the role of the spleen. So you do get splenomegaly, and if it's secondary, you'll get symptoms of the underlying disorder. If it was a lymphoma, the lymphadenopathy, any symptoms and signs related, let's say, to the HIV infection, etc. Yeah. So for the lab features, I really apologize for that cutoff, but you'll still get, for your CBC, you'll still get that, reduced HB. Often with hemolytic anemias, what we will see is either it's normocytic, yeah, but we can get a macrocytosis either because of these cells autoagglutinating, clinging to each other because of that antibody, yeah, that's latched onto them, and also because of the reticulocytosis, yeah. And then, of course, for your LFTs, you will get your unconjugated bilirubinemia being increased. Haptoglobin levels are usually low. You can get your urinary urobilinogen increased. Hemoglobinuria in this case is uncommon. For patients who then get, on top of this warm IHA, they also get an immune thrombocytopenic purpura. We call that Evans syndrome. And so in those patients, you'll also notice a low platelet count. So in the bone marrow, what we would see if you do a bone marrow, often not required for this, is there'll be erythroid hyperplasia because your bone marrow is trying to keep up with the cells that are being destroyed. So there's that, the erythroid component becomes hyperplastic, yeah? And if there is an underlying lymphoproliferative disorder, you might see those cells in the marrow. In terms of serology, because remember this is immune mediated, so serology is where we base our diagnosis. They're usually Coombs positive. And in the lab, if you remember, we had for your Coombs reagent or your antiglobulin, we have different components, so this might be a bit too much for you, but we can have one that is both IgG and complement, or one that is just IgG. So in this case, if you do have antisera that are specific, it's IgG positive. Okay. So for the cold, remember the thermal amplitude, the antibodies involved in this work best below 32 degrees. This is the one that is less common than the warm, maybe about 15%. And often we consider it almost a pre-malignant B-cell disorder. Like if you see a cold autoimmune hemolytic anemia, you really should screen and see, does this patient have an LP? What's going on? Generally, the antibody involved is an IgM that acts as an agglutinin and activates complement on the red cells. It may also occasionally act as a lysine itself. So in this case, your Crohn's will be positive, but it's the complement C3D that would be positive. So it's associated quite often with your B cell disorders, your lymphoproliferative disorders like a non-Hodgkin's lymphoma, or your chronic lymphocytic leukemia. Yeah. So IgM, that's the thermal amplitude, and you really should look for an underlying LPP. The two major types of cold antibody, we have the cold agglutinins and the Donat-Leinsteiner antibodies. Still feels like a bit of TMI, I should clean this up, but they can either cause immediate intravascular by complement-mediated mechanisms, or these cells are sequestered in the liver, remember the Kupffer cells, and that's where the RBCs that have been quoted are removed. Okay. Clinical features of chronic hemolysis. You can get acute hemolysis if temperatures drop. So we still call it temperate regions, or places where they actually do have like colder temperatures, where the weather is not as awesome as ours, you can get episodes of acute hemolysis. And we will often get, acrocyanosis, skin ulceration, and necrosis is uncommon, but we can get, fingertips turning blue. The jaundice is more mild. It's not as striking as for your warm IHAs. You can get some splenomegaly. It's good to remember that we can get secondary causes post-infection, like your mycoplasma, pneumonia infections, and these are often self-limited, but you can see a drop in HB. Yeah, the anemia is mild to moderate. On the blood film, you will see the agglutination I talked about for the warm IHA, but less of the spherocytes. If you remember from your lectures on from last year, okay, in this case, for the spherocytosis, what happens is, as your cells are passing through the spleen, yeah, and if they do have, they've been coated with antibody, and I don't know if any of you guys listen to some of those. There's a group of lectures, I'm trying to remember the guy's name, but forgive me if I'm just going to quote him without attributing it directly, but someone described it as the spleen seeing that red cell as yummy. So they bite out that section with an antibody. And so the red cell kind of reforms into a spherocyte because they've lost that section of membrane. And so that happens especially when the spleen is responsible or the spleen is mainly involved in sequestration, like in the warm IHAs. So in these cold IHAs, it's more of that direct intravascular, or in the liver as the site of extravascular hemolysis. And so we don't see as much spherocytosis. The direct anti-globulin test, or your Coombs test, is positive, and generally it's complement only. Yeah. I'm just going to mention paroxysmal cold hemoglobinuria as a rare form, but characterized by recurrent hemolysis after exposure to cold. It was formerly more commonly associated with syphilis. We're not seeing as much syphilis now due to access to care and antibiotics, but you can also see self-limited forms in kids after viral infections. And we've already talked about like your mycoplasma pneumonia. Yeah. And with PCH, we kind of get like this biphasic picture, in that the cells, the antibody exhibits like dual, like thermal amplitude. It like binds at the lower temperatures, but lyses at 37 degrees. And I'm fully aware that this is TMI, but just be aware that paroxysmal cold hemoglobinuria can occur after viral infections or infections like syphilis, and that's a cold autoimmune hemolytic anemia. Okay, the last one for the hemolytic anemias, I'm just going to do, are you still there? Check. Han, are we still there?
Yes, Doc, we are.
Okay, or am I still online? Okay, feel free to stop me anytime if you have a question or you need me to review something. Because I'm screen sharing, I can't see the chat box or any raised hands. So feel free to just jump in. Okay, so the last bit, after we've like gone through your autoimmune, I've just maybe very briefly mentioned your allo, but you'll go through it again when you're doing your transfusion lectures. Now, the drug-induced hemolytic anemias. So this is still an immune-mediated hemolysis. And there are three mechanisms, yeah? So either the drug can be adsorbed onto the red cell surface, and that happens with drugs like penicillin, or it can form a new antigen altogether, like the drugs like quinidin, or now have an autoimmune mechanism like alpha-methyl-dopa. It's rare, but it can be severe, and the diagnosis is made in 3 stages. I mean, apart from it having features of hemolysis, often the Coombs test is positive, and then the patient has that history of that drug ingestion, yeah? The demonstration of drug-specific antibodies is often outside of the scope, not only of this lecture, but also of the lab menu in terms of testing, yeah, because you can probably make or confirm the diagnosis based on history and the fact that there has been a hemolytic picture. But you can send this out as a referral test if required. Oh, okay, I guess I did put in slides on autoimmune. Please forgive me. Let me know if you want me to just gloss over, but let's just go through it just in case during transfusion it's not mentioned as much. So for the alloimmune hemolytic anemias, the 2 situations that we need to mention are the ABO incompatibility, which you will go through extensively, I promise you, and hemolytic disease of the newborn. And it's basically that you produce an antibody against a non-self. Yeah. So how did you get a non-self antigen? Yeah. So it was either introduced as through transfusion. Yeah. Or now, as we talked about in terms of a pregnant mother and has, this fetus who half their DNA comes from someone else, yeah, so they may have a different antigen profile, or it's been acquired by the red cells, and we talked about drug-induced, and we've got this, this antigen that now on the red cell surface that does not look like self, yeah. So for the alloimmune hemolysis due to anti-D, I think this should not be there, but I'm just maybe, okay. So this really shouldn't have been there. I should have edited it. It's just basically if you give a patient anti-D and they are D positive. And I think you'll go through that when you're talking about pharmacology. So that's it for the immune-mediated hemolytic anemias that are acquired. So it can either be, you form antibodies against your own antigens, and usually that's with immune regulation. And we talked about the thermal amplitude, and that's how we divide them. It could be against, non-self, those are allo, and we've talked about the ways you can get a non-self antigen, and we've talked about the drug-induced very briefly. I think we go into it a bit more detail with our pharmacy students, but basically there are some drugs that either can attach to the red cell surface, form a whole new antigen, or still stimulate a reaction that is autoimmune in nature. And in the end, you get this shortened red cell half-life. So the non-immune hemolytic anemias are vast and varied. But don't worry, we're almost done. So there's paroxysmal nocturnal hemoglobinuria, we have red cell fragmentation syndromes, we have Marchingglobineria infections, chemical and physical agents, and the secondary hemolysis. For PNH, for some reason, students usually like this, but I think I've seen like 3 patients in 10 years. But it's good to look at it as a pattern. I'm seeing something through the chat. So sorry. Okay, please repeat the alloimmune. Okay. Can I just do it like a bit at the end? Let me finish through this and then we'll go through alloimmune just one more time. Yeah. Okay. So for paroxysmal nocturnal hemoglobinuria, this is actually an acquired hematopoietic stem cell disorder. The reason that's interesting is, most of your other stem cell disorders are malignancies. When there's a problem with your stem cell, often not, because this is clonal, yeah? That clone is malignant. But in this case, we have a clone that has increased sensitivity to hemolysis by complement, yeah? And what happens is there is this anchor that's usually on the cell, like this glycosyl phosphatidylinositol anchor, the GPI anchor. And because there's been an error in synthesis of it, we get deficiency of any of the proteins that are anchored by this GPI. Yeah. And so it makes these cells, it's not just the red cells because it's stem cell, for the neutrophils, even for your platelets, they're more sensitive to lysis by complement. Yeah. So these proteins that are usually anchored by this GPI kind of protect your cells against destruction by complement that's around. But because they're not there, then we've got this increased sensitivity, and so we get hemolysis because of complement. For some reason, my slides are really cheap. Okay, so what are the clinical features? So hemoglobinuria, and this is where traditionally has been described as like coke-colored urine, first thing in the morning, but basically you do get this hemoglobinuria that usually is precipitated by a number of events. Could be infection, could be a fever, yeah. This nocturnal hemoglobinuria, although it's much touted and seen in a lot of books, is not as common. We get a chronic hemolytic anemia that can be quite severe, and it's coupled with an iron deficiency because of that hemoglobinuria. And this is something we'll mention in transfusion, and I think we mentioned it in iron metabolism last year, but your body doesn't have an efficient way of getting rid of iron. But when you lose red cells, either through donation or hemorrhage, that is one of the ways you will lose iron. And so you can actually get an iron deficiency if you get this severe and chronic hemoglobinuria. You can get bleeding as well, because remember, it's a stem cell disorder. And so the platelets are not, immune to destruction as well by complement. And so if you have thrombocytopenia, there's an increased risk of bleed, but these are patients who also get thrombosis. Yeah. So in the lab, you'll find that your FBC, in full blood count, you may have a pancytopenia. The anemia might be quite severe. You can get macrocytic anemia because of that reticulocytosis. Remember, your marrow is responding to the low cell count. It's trying to get it to a homeostatic level. And so it'll push up these younger red cells, these reticulocytes, and who are a little chubbier, their MCV is a little larger. And so that might reflect as a macrocytosis on your FBC. On the other hand, you could also have, I think that iron deficiency bit might be a bit TMI for this level, but if they do get iron deficiency, of course, it would be microcytic hyperchromic. In your urine, you can get a hemosidenuria, sometimes you get a hemoglobinuria, and we often talk about a HAMS test or lysis, increased lysis in acidified serum, because the cells are not able to protect themselves from complement degradation once activated. But now, we have better tests, so we use flow cytometry and just look for the CD markers on the cells themselves to diagnose your PNH. Okay, so not as common, but much beloved by students and previously by examiners. Okay, I'm seeing another chat. Yeah, so I don't know why the hemoglobinuria is nocturnal, Faith. And I'm just going to say it seems to be like an anecdotal report, because you'll see a lot of books talking about, when you wake up, coke-colored urine, but and they would previously people tried to hypothesize that there was that concentration because at night you get a bit dehydrated or you wouldn't pee as much and so it collects. But I don't know, it's nocturnal hemoglobinuria, even for the patients we see. And if you look at all the now more modern case reports, it's not as common, but it always, the disease seems to have covered or carried that tag. Yeah. And so when you get a case scenario when they're asking, they're like, coke-colored urine on waking, but it's not as common as it's reported to be. So I can't give you a conclusive answer to that, because I can just tell you that it's not as common. Yeah, it occurs throughout the day. Okay, but some of the theories that were put forward was that concentration at night, or that dehydration, collection of urine because you're not peeing as often. I hope that helps. I apologize if it doesn't. I don't have a good answer. So for the red cell, we'll discuss this at the end of the lecture. For the red cell fragmentation syndromes, now these give us quite a few problems. There are the thrombotic microangiopathies, or previously called the microangiopathic hemolytic anemias. Yeah. So this happens when there's intravascular hemolysis due to fragmentation of normal red cells as they're passing through abnormal vessels. Yeah. So what happens is there are actually like these little clots, especially in the smaller diametered vessels, yeah, like your arterioles, and these clots form, and then as the red cells pass through, they're shredded, yeah, and that's what causes the hemolysis, yeah. So generally, these happen when there are underlying disorders, quite common in the mucin-producing adenocarcinomas that you'll go through with the APT. But we see it in complications of pregnancy when you guys are doing your OBGYN rotation. You'll see quite a few patients with eclampsia or preeclampsia. And there's something that we get called in for, your HELP syndrome, which consists of hemolysis, and they have elevated liver enzymes and no platelets in. So they often present with these thrombotic microangiopathies. Patients who have DIC. So you'll talk about your DIC in hemostasis later this year, but basically it's a consumptive coagulopathy, and we form these little microclots even in the smaller vessels, and you can get hemolysis as the red cells are pushed through these vessels and they're just shredded by those fibrin strands. The ones that I think you talked about in micro, you talked about your E. coli and your Shigella and the sugar toxin and O157 for your hemolytic uremic syndrome, generally preceded by diarrhea, but we end up getting this hemolytic uremic syndrome where we do get these clots in the smaller vessels. It's accompanied by renal dysfunction and then now that hemolysis. For your thrombotic thrombocytopenic purpura, in this case, there is a deficiency of a metalloproteinase. This is TMI, just, I think you'll go through it again in IMED, but as you go through the pathology, you just remember that there are microclots formed because of this ADAM-TS13 is no longer there to help break up the bulkier bits of von Willebrand's factor. And so we do get these clots forming in the smaller vessels, and then your red cells are shredded as they pass through them. Some drugs like bleomycin and cisplatin, we should see quite a bit as you rotate through your oncology units. I think 8C, and maybe if you come to us in 3D for PETs, patients can get these MAHAs or TNAs as they're now called. Okay, lab findings, because the red cells are being pushed through these clots, they're shredded, then they form these fragments. And if you remember, those red cell fragments are termed as schistocytes. Yeah. Sometimes we do get like these spherocytes, and you will see reticulocytes and normoblasts because there's increased red cell destruction and it's premature. Your marrow's like trying to cope and it'll push out these younger red cells, and sometimes it'll push out young red cells that still have their nucleus. So those nucleated red blood cells are called normoblasts. Often these are consumptive coagulopathies, meaning that they're using up, these the players in your coagulation pathway. So, like for your TMAs or MAHAs, there's a thrombocytopenia platelet count is quite low, and for your DIC, remember you'll find now your coagulation pathway is quite like if you do your coag screen, you'll find prolonged APTT, PT, because they're using up all of these coagulation factors, forming these clots, but still we result in bleed. Yeah. So you do need to treat the underlying cause. It can be quite difficult to sort out. Yeah. So fine. The second one was the traumatic cardiac. I'm trying to remember what I put as number one. Forgive me. Oh, okay, maybe it was the red cell fragmentation syndrome. So traumatic cardiac hemolytic anemia, you see that in patients who have prosthetic heart valves or patients who have cardiac valve disorders. So patients who are, I think if those who might, when you do your surgical rotations post, I think 4D or in your IMED rotations. So you can get actual damage to the red cells as they're pushing past these damaged valves or these prosthetic valves, and they're shredded. Yeah, it's usually quite mild and well compensated. By well compensated, it means you might not see a drop in HB, but or you see a minimal drop in HB, but your marrow is able to respond adequately and push out enough red cells. Marchingglobineria, for those of you who will take place in, have we had the Stanchart Marathon yet? I know there were guys who were running virtually, but for those of you who do quite a bit of distance running or hiking or friend ride year long, you can actually get damage to red cells between the small bones of feet. And actually we see these after, when you get these recruitments for police or army and they go for those camps, you can actually see this afterwards, yeah, because they've gone for maybe prolonged march or running that they've done, they don't usually do. You might not see the fragments in the blood film, but you get like, now that coca-colored urine. And it's because, of the time on your feet, and you're actually getting physical, like damage to the red cells between these small bones. There are a number of infections that can cause hemolysis, and in a number of ways. You can get acute hemolytic crisis in glucose 6-phosphate dehydrogenase deficiency that is precipitated by an infection. You can get things like Neisseria, causing that thrombotic microangiopathy. So Neisseria meningitidis. You can get direct invasion of the red cells by the infective organism. For example, malaria. The malaria actually causes hemolysis in a number of ways, but you can actually get, remember, if you recall from the life cycle of malaria, after it's gone from the liver stage, and you get these trophozoites in. If you remember the schizogony, and when they multiply and then they just, how they get out the cell is they cause that lysis, yeah? And then now before they go on to infect another cell, so that causes hemolysis. There's some bacteria, for example, Clostridia, that elaborate toxins that are actually hemolytic, yeah? And then, or infections like viral infections that may actually result in the production of red cell autoantibodies. And your viral hepatitis, for example, your hep C, or your CMV or Epstein-Barr can actually lead to this, yeah? Or your HIV, which I should have mentioned as well. Okay, for the chemical and physical agents, some drugs cause oxidative damage in high doses, for example, your dapsone. Or if you have high levels of, for example, your heavy metals like copper, or in Wilson's disease, or in lead poisoning. Severe burns can cause actual physical hemolysis. There are hemolysins. When you're doing your snake and spider bites, some of them are hemolytic, apart from the neurotoxins, and they'll cause hemolysis. Or in situations that are metabolic situations like hypophosphatemia, you can get hemolysis. We do get secondary hemolytic anemias that are, not directly because of it, but a shortened red cell survival in a lot of systemic disorders. So in renal failure, even with uremia, not only do you get red cell shortened survival, but even platelets may not work as well. In your liver disease, and this may also be attributed to how your body handles cholesterol, yeah? And if you remember, your cell membrane is made up of cholesterol, and so we do get, these acanthocytes or target cells are directly as a result of that. We do have Zeev syndrome as one of the causes of a non-megaloblastic macrocytic anemia. But in this case, we get an acute hemolytic anemia with intravascular hemolysis and hyperlipidemia with abdominal pain in patients who are alcoholics, yeah, or have an alcohol dependency. I'm not sure what the PC term is right now, but we do get that in those situations. Okay, fine. So I'm going to stop the share and talk about very briefly about your alloimmune as I try and look through the rest of the chat and see if there are any other hands up. So when we talked about the immune-mediated hemolytic anemias, for your alloimmune, this is when you have an antibody that's directed against non-self. Yeah. So how did you get the non-self antigen? Yeah. So it could be from transfusion. Yeah. It could be that you have, for the pregnant mom, something inside you that is, half the DNA is from elsewhere. Or you can get, okay, we won't talk about post-transplant at this level. Yeah. So for the alloimmune, the situations that we think about are, one, ABO incompatibility, because those are the ones that cause really brisk, rapid, acute hemolytic transfusion reactions. Yeah. So if you're given ABO blood group that is not yours, then you will get, hemolysis quite rapidly. Yeah. And if you remember, the purpose of the transfusion is to raise your blood count. Okay, Cynthia, I see your question heading there. So we need that as a therapeutic it's therapy. And we need the red cell to survive because you're being given a transfusion to raise your HB or blood count. And so we usually give you something that you're compatible with so that these cells, even though they're not your cells, survive as long as possible to try and carry out the function that they were supposed to do, which is increase your oxygen carrying capacity, which is why we do now, the blood grouping before we transfuse and the compatibility testing. So the other thing that may happen is we can talk about the hemolytic disease of the newborn. That's still under your alloimmune. So this can happen in, two ways. Usually the scenario we tell you about is your RHD incompatibility, whereby you have a mother who's RHD negative and the baby is RHD positive, meaning her partner is RHD positive, yeah? So during the first pregnancy, if there's an incidence of fetal maternal hemorrhage, like is there some way the fetal cells enter maternal circulation, and that would happen even during delivery, yeah, then the mother becomes sensitized and may produce antibodies against the D antigen. Then in a subsequent pregnancy, if she has another fetus, it might not be the next immediate pregnancy, but any subsequent pregnancy, and she has a fetus that is RHD positive, and again, either through, mom had a fall or there was manipulation, like, amniochoreocentesis or during delivery, anything that can cause fetal maternal hemorrhage, and the mother becomes aware, or the mom's immune system becomes aware that, look, there's RHD antigen somewhere here. So her immune system responds. We've seen this before, and we know it's not us, produces antibodies, which then cross the placenta and attack the fetus, yeah? So what happens is when you do your OBGYN rotation and when you're practicing, you will, these are pregnancies that are usually handled in a high-risk clinic, and they're offered anti-D, either 28 weeks and at birth or after each episode of a fall or something that might trigger a fetal maternal hemorrhage, so that the mother doesn't produce the anti-D, and so that, the mom doesn't try and destroy the baby, yeah? But uncontrolled usually will lead to pregnancy losses because, the mom's immune system is really just trying to attack. So that is one for RHD incompatibility. We can have ABO incompatibility, which is less severe. Yeah, I feel I'm really heading into a lecture that should be happening in a different session, but you did ask. I'm just gonna, if anyone wants to blame someone for the extra time, okay, I'm not gonna, it's Bashir who asked, so not for him. But anyway, for the ABO incompatibility, it usually happens when there's a mom whose ABO blood group is O. And if you remember for blood group O, they don't have like either A or B antigen on their red cells. So what they have in circulation is anti-A and anti-B, right? So if she has a baby who's blood group A or blood group B, a fetus, yeah, meaning that her partner was not blood group O, yeah, then moms, those antibodies can cross the placenta and attack the baby's blood cells. So it's usually less severe for a number of reasons. So outside the scope of this lecture, but I will just mention. Often your anti-A and anti-B for blood group O are IgM, which are bulky, which don't cross, but we do have an IgG component that do cross. Two, the baby's antigens are not as developed, and so we don't get as severe a hemolysis and ABO incompatibility. Yeah, so or hemolytic disease of the fetus and newborn ABO incompatibility. So it does happen, and we do get hemolysis, but the anemia is not as severe. It's more mild, and you get a less marked elevation of your bilirubin or your derangement of your LFTs. Okay. I think you guys will go through the management in peds, but those are the two scenarios we talk about for allo in terms of incompatibility. I don't know if that's okay, Mr. Bashir, or you need me to. Are we okay with that? You can just say yes or no. If you're still here. Okay. Okay, great. Thank you so much. So, okay. So I think, Faith, we talked about the hemoglobinuria and the nighttime nature of it. I don't have an answer for that. I've told you the theories that I've read up on in terms of the concentration, in terms of not peeing, and so it collects. And even that nocturnal, it's not as common as reported. So I really can't give you a clear answer to that. But if you find a paper that gives you a good reason, let me know. But since it's not as commonly reported as previously has been indicated, it may not be as important. But it may come up in a case, an OSCE when you guys are being examined. So maybe if you see coat-colored urine in the morning, you can try and think of your PNH. For Cynthia, spherocytosis is less marked in a cold IHA than a warm IHA. So it's IHA, A-I-H-A. So generally it just is. I was looking at the pathophysiology in terms of the spherocytes. You really don't need to know this, and I don't think my answer is very scientific. But for your warm IHA, the main site of extravascular hemolysis is your spleen. Yeah. And this is where you've got all, even for your senescent red cells, that's the main site of destruction, right? And they generally, once this this immunoglobulin is latched onto the red cell, what happens is the spleen can actually take out that portion of cell where either there is that defect or there is that immunoglobulin, and then the cell reforms. And because that membrane loss, it reforms into a spherocyte. Yeah. For your cold IHA, a lot of the hemolysis is either direct, intravascular, but if it does have an extravascular component, it's the Kupffer cells in the liver. And I'm not sure they're able to perform the same function. So I'm saying I'm not sure if my answer would be scientific enough, but generally what we see for the cold IHAs is less of that spherocytosis and less of a marked, reticulocytosis. I don't know if that helps, but I was trying to explain it from the site of extravascular destruction. Okay, well, let me know if I helped or not. You want me to review that. Okay, trying to look through very quickly to see if there are any raised hands. There are many, so it would help if you just unmuted and asked if there is if there's a raised hand. No. Okay. All right. I might just be background noise for someone's house. All right. Okay. For Marchingglobineria, no. Does it occur in all distance runners? No. It is something that can occur, and the mechanism is now that trapping and destruction of red cells between now the small bones of the feet, and then what you get is I don't know if you've done distance. I myself have not, but if you have friends or you run yourself distance, you'll find that sometimes after a long run, people can actually, will tell you that they notice their pee is quite a different color. And it's not just the hemo concentration, but it can actually be hemoglobinuria itself if it was tested. So it's not all, and it usually occurs after quite a long distance. Yeah. I don't know if that helps you with me. It does. Okay. So barring any, okay, great. Thank you so much. Barring any elevated hand, or anyone wants to unmute and ask anything? Or are we good? Okay, can't see anything else. Okay, I'm not seeing anything else in the chat, but feel free to reach out if there's any issue, if there's anything you'd like me to clarify. I'm notorious about not sending PowerPoints, so please forgive your class rep if he's asked me 10 times and I just simply forgotten. But I will try and clean this up and send it. Mr. Khan, if you could please remind me. That, yeah, okay. I've given you fair warning, so no one should kill you. I'm really bad at this. Yeah. Okay. On RHD. So now I'm not really sure what you want me to repeat on RHD. Is this the hemolytic disease of the fetus and newborn, or the mechanism? The mechanism of action of anti-D, or just the whole thing? Sorry, I can see it's a DM, but okay. So very briefly, hemolytic disease of the fetus and newborn. Okay, fine. How hemolysis occurs. Is this for hemolytic disease of the fetus and newborn, or a patient who's been given anti-D? Because there's a brief bit on the slide that I should have taken out. Okay, fine. Of the newborn. Thank you so much. Hey, you're really quick with the testing in the chat. Thank you. That was really helpful. So I'm just going to repeat it again because you will come across it both in transfusion and in OBS. Yeah? That we can get incompatibility with regards to the RHD group for the mom and the fetus. So if the mom is RHD negative, remember they don't have, that means they don't have the RHD antigen, but her partner does, and she gets a fetus, you know, they conceive and the baby is RHD positive, then during the first pregnancy, it might not be her first pregnancy, but a first pregnancy with an RHD positive fetus, there's fetal maternal hemorrhage, which is quite likely to occur during delivery, etc. Yeah, then you get these fetal red cells that end up in maternal circulation, and mom's immune system is like, you know, aha, we don't know this. Yeah, this RHD antigen is not self, and so they produce anti-D antibodies. Okay, so during the next pregnancy is now when it's a problem. The next pregnancy with an RHD positive fetus. Because if we get another episode of fetal maternal hemorrhage, mom's immune system is already primed. She's been sensitized. And so she produces all these antibodies against RHD antigen, right? And these antibodies cross the placenta and destroy the fetus's red cells. So that's why we get hemolytic disease of the fetus and or newborn. So it depends on how early in pregnancy. It may result in a loss in pregnancy. It may result in, you know, hydrops vitalis because of all that bilirubin that's there. You get this, it acts as an osmotic, it has an osmotic pull, and, you know, baby swells up. Or we might get anemia, babies are delivered preterm, you know. And so how we counter that is that for moms generally at 28 weeks and at delivery of 32 weeks, we give them anti-D. These are moms who are RHD negative, yeah, so that they don't produce the anti-D themselves, yeah, and so that they don't destroy the baby's red cells. And this can occur also after any trauma or any invasive procedure where you suspect fetal maternal hemorrhage. So it's, you usually won't see hemolysis during the first RHD pregnancy. It'll be seen on the second when the mom has been sensitized. I'd like to remind you that 97% of our population are RHD positive. So this is not as common as what you will see. If you practice outside, you'll see quite a few, especially in Europe or the US. They have a higher percentage of population who are RHD negative. So it's much more common there. What you will see here is a bit of ABO incompatibility, yeah, where mom is, you know, blood group O, but that's not what you asked about. So I'm not going to dwell on it. But what I will mention is that these are often direct Coombs test positive or DAT positive because we are forming antibodies. You know, it's an allo. We're forming antibodies against non-self. So your anti-IgG, your Coombs reagent, you will test positive, yeah, for the baby. It's DCT positive. And mom, it'll be indirect Coombs, but we'll go into that for when we discuss your transfusion lectures. I don't know if that is okay for the person who DM'd me. Okay, awesome. Thank you so much. All right, thank you so much, everyone. I'm assuming, great, that there are no other, I'm not hearing you. If you do have a problem or a question, please let me know. I'm happy to review, but other than that, yeah, I can see we've like lost 50 people already. So guys are tired. So yeah, thank you so much. I'm sorry again for starting late. Thank you for your attention. I think we'll meet again during the transfusion lectures if I'm not wrong. Thank you so much. You guys take care.
Thank you, Doc. Have a good day. I'll remind you on the slides.
Thank you. All right, you take care.
Okay. Bye-bye.